Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei niin kuin ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who in effect can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
Hello, good morning or good afternoon, good evening, wherever you are in the world. My name is Maurizio Cecconi. I am the president of the European Society of Intensive Care Medicine. Today I'm particularly excited about co-chairing this webinar. It is a joint webinar between the European Society of Intensive Care Medicine and the European Respiratory Society. So it's a kind of a testimony of the collaboration that we've seen between the professionals that we represent with both societies. The collaboration between intensive care and respiratory units and respiratory professionals has always been key in the job that we have been doing for many years as intensive care professionals. But even more during the last 2 years, I think this has become paramount in a way to try to care for so many patients with continuity of care and with the best possible way for our patients. Today, the topic is a topic about palliative and end-of-life approaches in the ICU and the respiratory support unit. I'm very excited to welcome also my co-host, Professor Anita Simons. Anita is a consultant in respiratory and sleep medicine, a professor of respiratory and sleep medicine at the National Heart Lung Institute at Imperial College London, and is also a past president of the ERS. And Anita and I, we had met a few times to discuss on how to best support frontline clinicians in the last few months. Hello, Anita.
Hello, and thank you so much, Maurizio. We're really glad about this collaboration. As you say, as teams, we have always worked well together for the management of our patients. I think that integration of care has been enhanced during COVID, and I very much hope will continue in the future. And this will be the first of many such webinars. So to move on, it's my great pleasure to introduce our first speaker, who is Professor Stefano Nava. He's Professor of Respiratory Critical Care Medicine at the University of Bologna. He is a lead clinician in respiratory critical care at San Orsola Malpighi Hospital, and he is a pioneer of non-invasive ventilation over many decades. He has developed NIV, he has used it for weaning, he has looked at the physiology of NIV, and in particular too, he has looked at the role of NIV in palliation of breathlessness and symptoms. And it's on that topic, palliative non-invasive ventilation, that he's going to speak now. Stefano, thank you.
Thank you, Anita. Thank you, Maurizio, for the invitation. Good morning, good afternoon, good night, wherever you are based. And my task today is, as Anita said, to talk about palliative NIV, a very controversial issue. Well, these are my conflicts of interest. I would like to start with a sentence from the movie Take Your Money and Run. This is Woody Allen, you for sure recognize. And he said something that I share also with him, and I think with most of the people: we are afraid to die. He said, I'm not afraid to die, I just don't want to be there when it happens. Well, this is a typical behavior of the clinicians, and obviously of all of our patients and relatives. Well, I start with a little bit of science and fiction. This is partially true, obviously. It's one Monday morning, the chief is asking to the attendee, how was your night in the emergency room? The attendee, I'm exhausted, 35 admission tonight, one guy was stabbed, 2 drug overdoses, few cardiogenic pulmonary edema, several patients, very popular here in Italy, with white coats. Basically, they didn't want to queue in the GP's office. Oh, yes, I forgot. 174 years old cancer patient, metastasis all over, the third admission in 10 days. This time he came for dyspnea, the same old story. He claimed that he cannot stay at home alone. Chief, who is he? Maybe Mr. Brambilla. Oh my God, oh no. The oncologists were very clear. No space for any further therapy. I called last time Dr. Bedluck, and he said that the unit was so busy. Well, we may try the palliative care unit, the attendee said. What? No way. Dr. Graveyard was telling me that the waiting list is so long, and you know they claim they can deal with pain, but not with dyspnea. Well, any further idea? The attending, Well, we may call the pulmonologist and claim that we have a case of COPD patient with respiratory distress. As a matter of fact, Mr. Brambilla is also a COPD, I guess. Did he smoke? The chief? Well, I guess so. The attendant? So easy enough. Is a COPD, will never lie. I will contact Dr. Breath, that is a real family name. The chief? Brilliant. I will propose you for promotion. It's not by chance that your name is Foxy. Well, this is a sort of science and fiction, as I said before, but this is something that reflects quite closely the real life. Well, where is the ethical problem here? I know that medicine stated that more or less there are three main issues when we talk about ethics in this condition, end-stage patient. We do not want to waste money. We do not want to consume healthcare resources. We do not want people to suffer, unduly delaying the time of breath. And last but not least, respect the patient wishes and preferences. And you may claim, what are the preferences of end-stage patient? Well, concerning, for example, COPD patient, we are dealing here with a sort of mixed pathology, cancer and end-stage COPD. 4 items were identified. And today we are going to deal with what I think is the major issue here, symptom control towards the end of life. I don't like to call it dyspnea. We call pain when the patient has pain for whatever reason, and I like to call dyspnea the pain of breathing. And my talk is going to be obviously devoted to this specific topic. Well, I like this study that I'm showing. This is an old study by Randy Carty's group, the quality of dying. Not only quality of life, but also quality of dying is important. Well, the author asked to 3 different groups of professional, nurse, resident, attending, plus family member, how were the last moment of life of their beloved one. 0 means terrible, 10 almost perfect. Well, as you can see here, dyspnea was the second worst item. Interestingly enough, while the attending physician, well, we were quite satisfied about breathing at the end of the life in their patient, the residents were not happy at all. So we have a problem. What can we do for this patient? What can we do for Mr. Brambilla? Well, these are the very recent guidelines in which I was also involved of the Oncologist Association in the US. Management of dyspnea in advanced cancer. Recommendation 5. Systemic opioids should be offered to patients with dyspnea, but interestingly enough, they state something that I found extremely important. When non-pharmacologic intervention are insufficient to provide dyspnea relief. Evidence low, strength, or recommendation moderate. What are these non-pharmacologic interventions? The first one is NIV, and we state in the recommendation, a time-limited therapeutical trial of NIV, if available, obviously, may be offered to patients who have significant dyspnea despite standard measure and do not have contraindication. Once more, the evidence is not as good as we hope, but we share the same level of evidence as for opioids. Interestingly enough, nothing to do with NIV, but we were quite strong in not recommending supplemental oxygen when SpIO2 is higher or equal to 90%. Well, I bet with you that in your hospital, 99% of the patients with dyspnea and end-stage disorder, despite of the level of saturation, will be treated with oxygen. It is extremely important to understand what is the meaning of NIV in this condition? In this condition, when NIV is applied as a palliative cure, the definition, as here stated in the this consensus conference by the American and Canadian Association, the definition of NIV as palliative cure means comfort measure only, palliation of symptoms, relief of dyspnea. And interestingly enough, the goal may be also to maximize comfort while minimize adverse effect of opiates, and eventually give time to the relatives of a patient to say hello to their beloved one. Is it used in real life? Well, in this quite old already survey that we did with Anita and the ERS in the respiratory intensive care unit, we find out quite surprisingly that 15 years ago, more than 30% of the patients in the high dependency unit were received NIV mainly as a ceiling treatment. This does not necessarily mean palliation, because there is also a mixture of DNI option and palliation option that does not every time combine together. And the case was well illustrated by my co-speaker, Elie Azoulay, and he showed that quite large proportion of patients admitted to the ICU were receiving NIV as a ceiling treatment. He also showed a different survival rate among the different kind of diseases. You can see here the difference between COPD, heart failure, pneumonia, and cancer. But interestingly enough, one of the main concerns of using NIV either as a ceiling treatment or as a palliative tool is that some clinicians think that we may deteriorate quality of life. And as a matter of fact, Elie showed exactly the other way around. There was no decrease in health-related quality of life. So let's see what are the clinical results about the utilization of NIV in the end-stage cancer. Because this is a case that I'm presenting you today, but this can be applied to all the end-stage diseases. In this pilot study, we just challenged the hypothesis that the application of NIV in patients with dyspnea and end-stage disorder may improve after 1 hour dyspnea. As a matter of fact, we obtained a statistically significant improvement. However, you have to see here that some patients, they responded well, some other they did not respond at all, and some other they didn't like the application of NIV at all. So we decided to perform a quite large study that was published in 2013. This was by far the most difficult study that I performed in my life, very demanding. So we randomized 200 patients with end-stage solid tumor and severe dyspnea, stratified according to the level of CO2. On the right side, those patients with hypercapnia, PaCO2 higher than 45. On the left-hand side of this flowchart, patient with PaCO2 equal or lower than 45. They were randomized to standard oxygen or NIV. Standard oxygen obviously was applied because oxygen saturation was on average below 90%. Well, these are the results. And here is the beauty or worst of medicine. I don't know. It depends how you present the data. If I want to be optimistic about the use of NIV, I will present you this slide as follows. On the x-axis, you have the first 2 days of observation. On the y-axis, you got the ball scale. As you can see here, patient represented by red circle, they decrease much faster and significantly better the degree of dyspnea versus those patients on oxygen therapy. And therefore, you can conclude that NIV is very effective in reducing dyspnea compared to oxygen in end-stage cancer patients with dyspnea. However, you may also see this other slide in which we separate the group of people. And first of all, we observe that the group who did much better than the other was only the subset of patients with hypercapnia undergoing NIV. So my first point here is that it is true that NIV may improve dyspnea in end-stage cancer patients. However, this is mainly due to the reduction probably in work of breathing of patients with pump failure. But on the other side, if I want to criticize my own work, I would say that we start with a quite high level of dyspnea, more than 6 on a Bohr scale. And at the end of the day, that means at day 2, 48 hours, we still have a significant degree of dyspnea that it was over 4, but is still consistent degree of dyspnea despite the application of NIV. So you can see, as most case of medicine, the glass half empty or half full. It is true that NIV may help the people to reduce dyspnea, but this works only in a specific group of patients, and then this is not a sort of magic tool. Still, this patient experiences dyspnea. I think one of the most important result of this study was the fact that we could reduce, using NIV, the amount of dyspnea of morphine that we were administered to the patient. And this was one of the aim. You remember that I show you concerning the consensus conference of the Canadian and US Society. So you can get a reduction in dyspnea using less morphine or opioids in general. Well, is it working everywhere? I'm not 100% sure. There are very few studies in the literature, but in this quite recent study published in the +1 medical journal, in this patient with DNI status severe dyspnea, in which NIV was used as a ceiling treatment, NIV was not, as Ali says, associated with a decline in health-related quality of life, good. But on the other side, NIV did not provide significant relief of symptoms in more than half of the patients who receive it for that purpose. And therefore, these highlight the paramount figure of the patient. Is the patient that in this condition is driving what you do. They need to decide if they want to keep going or not. So one may criticize the use of NIV as palliative tool because you may theoretically increase anxiety and sufferance, unduly delay the process of dying, and as the American said, you may also increase the cost. Is it true that you may increase anxiety? In this paper published on the European Respiratory Journal, in a population of patients admitted to the ICU for acute respiratory failure, the level of dyspnea was quite high, and dyspnea after the first NIV session was associated with anxiety. So you need to consider that. You need to consider that you need to be very good as a team to convince patients to stand at least the first initial trial to NIV, despite it may increase anxiety. But we need also to understand what then persistence of moderate to severe dyspnea after the first hour was associated with longer length of hospital stay and hospital mortality, despite once more not associated with impaired quality of life. So always be aware of this potential problem of anxiety. What about the other problem? unduly delay the process of dying. Is it the case? This is scary up to a certain point. Then the systematic review on the topic show that in a patient with DNI order, most of them in which NIV was applied as a palliative tool, show that NIV achieves survival with an acceptable quality of life. And in contrast to claim by some experts that NIV in this patient do not prolong the process of dying. So let's go back to Mr. Brambilla. It is true, he was a COPD, last FEV1 were 980. He got a gastric cancer 8 months before, liver and bone metastasis. IBGs at the time of admission to the emergency room was as follows: 7.29, CO2 70s, PaO2 50s, breathing room air. Obviously, it got ICU admission denied and transferred to our unit. The fact that he was perfectly competent and he asked to be fully supported because he really wished to say hello to his only son and the 2 nephews. And this is real life, it's not fiction. This is the case, August 7, 2019, summer season. You see here the evolution of arterial gases and dyspnea in yellow in the first 5 days. After days 4, we get rid of NIV. It did well. Dyspnea improved, even though, as we show, was not back to 0, from 6 to 4. The blood gases improved, and he was able to breathe spontaneously on day 5. However, there is a nitty-gritty of this. It was really impossible to contact any relatives, even through the police. You know, it was holiday season, and at the end of the day, he expired without even seeing any, I would say, love with a question mark once. So in conclusion, when, as Bob Dylan was used to say, is getting that to see, I think that the relief of symptom is mandatory, not only from a medical point of view, but also from a medical point of view. We need to consider patient preferences, control symptoms, use drugs or NIV, organize home care program to relieve their burden eventually if they can. But most important, imagine eventually, if it's a chronic patient, together their future and take in advance the right decision about the end of life. And this is an assist, as in football, from my friends Eli. And last but not least, avoid to unduly delay life and suffering. So for our young colleagues, I really suggest them to see this movie. I think movies are important. Read books, see movies, not only medical tests. Talk and listen, Hable con ella di Pedro Almodovar, consider the patient needs. Ingrid Bergman through a glass darkly, take together the decision, El mar adentro di Alejandro Amenabar. Do not prolong suffering, Les Invasions Barbariques by the French-Canadian director Denis Arcand, and last but not least, Le Scaphandre, Le Papillon di Julien Schnabel, Johnny Got His Gun by Dalton Trumbo, a very strong movie about dying and about war, and last, the very famous movie, $1 Million Baby by Clint Eastwood. And once more, I thank you for your attention. Thanks.
Thank you, Stefano. That was a wonderful presentation. I'm sure Anita agrees with me. And just to remind everyone, we will take questions which we are monitoring now from the chat and the platform. So we will answer those questions later after the last talk. And so without losing any more time, it's a great pleasure to welcome Eli Azoulay. Hello, Eli. Eli is the president-elect of the European Society of Intensive Care Medicine. Is also a former editor-in-chief of Intensive Care Medicine. Is the director of the medical ICU of St. Louis Teaching Hospital in Paris, in France. He's led several research groups, in particular for the topic of today is also acute respiratory failure and outcomes in critically ill immunocompromised patients. and we look forward to hear your talk, Ellie.
Thank you very much. Good morning, good afternoon, good evening, everyone. And I'm very happy. As you can see on my first slide, I will focus my presentation on communication with family members, which will be the bridge with the presentation from Stefano. I have no conflict of interest, but the deep happiness of sharing this ERS Yes ICM session, and I'm very much grateful to Professor Anita Simons and Maurizio Cecconi for making it happen. I think it's a very important event for our two societies. Well, as you know, we have a continuum in an illness trajectory from the diagnosis until the end of life. There are people who are not affected directly by the end of life themselves, but they are affected by bereavement. And in a country like France or like Italy, those people are 1 million people every year, and they are family members. And the bridge between what we call curative and palliative care is something that happens at the beginning. And we know if in the example of Mr. Brambilla, with a cancer, we know that providing elements of palliative care quite early in the management of intractable cancers is also prolonging life and making life better, end of life better, and bereavement better. So this concept of providing patient-centered care at the same time we are providing family-centered care is something that has been not only designed, but also really delineated since many years by ICU physicians and nurses, so that together we are able to manage at the same time patients and family members. A few years ago, with a constellation of symptoms that make end-of-life and end-of-life care for family members and gives a sense to what they have, we understood at the same time that we needed to move from the psychiatric evidence to a holistic evidence. Of course, family members have a post-ICU syndrome as much as the patients. At the same time, understanding all these symptoms make that we are committed to make this experience better for family members. Improving the family members' experience is also a commitment that we have all taken together, and we are making our best not only to focus on what is happening in the ICU, but also what will happen after ICU discharge. One of these examples is to understand that these family members will go through processes. One of them is grief. And we need to understand that we don't have to affect the different elements of grief. We need to understand that when we target our ICU interventions, we are also able to make this bereavement time different for family members. So we are in capacity of doing ICU things that we have long-term outcomes for family members. And these long-term outcomes also is our ability to reduce or to shorten the complicated grief that affects more than 60% of family members when the patient dies in the ICU. And the last thing, and this evidence comes from Brazil and has been shown in many different opportunities at many different times in the ICU, is that sometimes family members are more affected than ICU survivors, so then we need to put energy also on family members. The last point to show how much family members are vulnerable is this evidence that is now something that we are very much aware of, is that when someone dies in the hospital, we know that the other part of the couple, the spouse, has more risk, an increased risk of being hospitalized and even of dying in the year that follows the patient death. So we are really facing vulnerable people. So why are those family members so burdened? And I think that there are many different elements that are related to their history, to their personality, to the link and the relationship they have with the patient. But I would like to focus on our ability to communicate better, to target possible improvements. One is about visiting policies, improving understanding, improving the way we communicate about death, the way we address family needs, and sometimes to listen to family members, because this is something that we should learn more. Active listening is really something that provides the family members with opportunities to voice concerns, ventilate emotions, and we know that these 20-30 minutes that you are going to provide in the ICU, of course, they are on top of everything you have to do, but they are going to spare weeks and months of complicated grief. So, as you know, the family interaction in the ICU can be either a monologue. I speak to family members, I provide as many information as I can, and I hope, or I can hope, that family members will understand what I've been saying for days. And actually, when we measure family comprehension, we can see that after 5 to 7 days after ICU admission, 50% of family members have an inappropriate understanding of all what has been said. The other option is more into a dialogue. So you provide information, but you still make your best to build a partnership and to build trust. And it's a much more advanced relationship, but still it's not the way where family members will provide you with the solutions, because there is a problem, but family members are also providing solutions if only you're able to listen to them. The true communication is when you can spend time with family members and also listen to them, because this active listening will provide not only the evidence that they have concerns, but also the way you can resolve the concern and assist them. So the first element, which is providing information, still needs improvements. And we know that the tell, ask, tell requires some skills. We not only need to provide information, but to check the understanding immediately. So I can understand that your ability, your first ability is to provide information, and this is much better than nothing. But then you would need to improve your communication skills so that the information that you are providing is at least understood, because this is the minimum where we can empower family members. A very simple intervention, and of course this is something that has been published 20 years ago, is to provide family members with a basic information leaflet. You know, something very easy with a glossary to explain the ICU words, with a picture of an ICU room, with the minimum you know, not less than providing telephone numbers and the way you are enabling family members to visit the ICU. And only with a very simple information tool, you can improve comprehension. And comprehension can also be associated with an improvement of satisfaction. Of course, this is basic. I'm not sure that we can redo that today, because family information leaflets are provided everywhere, but that was at a time where very, very few was provided to family members. When we look at the literature and at randomized controlled trials, we can see that there are 3 kinds of interventions that have been provided to family members. One is something that focused on patient outcomes. The other one is that you do things and you are targeting family outcomes. And sometimes, and this is a lot with palliative care interventions, you're at least trying to reduce the consumption of ICU resources. And one of the major outcomes will be length of stay. Because length of stay not only addresses the issue of providing non-beneficial care, I don't like the term futile, and it's also a way for family members to accept to move from the curative to the palliative care. As you can see here, we have different studies, but only 13 trials were retained for this systematic analysis. And these are the results, is whatever you do, if you do very focused and targeted things, you will have difficulties to improve family outcomes, because it's a group of things that should be done. So we need to move from, of course, basic information, from dialogue to something that is more into communication. And if you remember, at the end of the 90s, the support investigators in the US provided a list of negative trials at the end of life in the ICU, and their conclusion was a very important one, is that we needed to do proactive interventions. It's not something that you provide and offer to family members. It's something that you need to bring to family members and to deliver the best of you, what you can, but you need to bring it to family members. I might just mention the negative trials, but there are also 3 trials, including one that we did, that provided exactly the opposite effect. One is about a palliative care intervention. The other one is in a communication skill intervention with a simulation model. And the other one is that we sent a condolence letter to family members of patients who died in the ICU. And these 3 interventions were associated with increased PTSD, post-traumatic stress disorder, or depression. So we not only need to understand that our focus is the ICU. We don't need to intervene after ICU discharge because it's a time where family members are building bereavement. They're entering into a process in which we don't need to intervene. So everything we need to do is something that we do in the ICU. And we have a trial that has been performed by my colleague Nancy Kentish-Born, who is doctor in sociology, a trial that is performed in the ICU and provides the best of end-of-life care. And this trial will be soon published and shows a very dramatic reduction in complicated grief and post-traumatic stress disorder. With Randy Curtis, with a group of qualitative studies using audio registrations and recording of family interviews, they were able to identify targets for improvements. The value mnemonic from Randy Curtis is not only something that has been every point of the mnemonic has been demonstrated in a study, but also the group of interventions was very easy to perform. This was designed by Randy and applied in a randomized control trial that we performed in France. The elements, for example, were to provide family members with time to voice concerns. If family member was able to speak and ventilate emotions, so then it was associated with a decreased post-ICU symptoms. For example, if family speech was increased, satisfaction was also increased. If family members had opportunities and we were able to see the opportunities to address different concerns, so then they had an increase in satisfaction. So this value mnemonic has been evaluated in a randomized control trial published in 2007. This trial was performed in France and was able to demonstrate a dramatic reduction in symptoms of anxiety and depression and in symptoms of PTSD. And in the trial I just mentioned that is going to be published in a few weeks, not only the end-of-life family conferences were performed in 70% of the cases in the control group, so now it's almost the standard of care, but again, this was associated with a dramatic reduction of the same post-ICU burden. What are the other trials that I would like that you keep in mind? One is about family presence. For example, when you provide clinical examination to assess whether the patient is brain deaf, and you have the family member present in the room, you can see that then family members will have an increase in the understanding of brain deaf without increasing PTSD and depression, showing that not only you're able to improve communication, but also without worsening the post-ICU symptoms. Family present during CPR. You remember the Robinson trial on 18 patients published in The Lancet in 1998 and raising the hypothesis that it was not harmful. So that was actually confirmed in France in a trial performed with the SAMU, you know, the pre-hospital ambulances. So family members were either invited to stay away or to witness CPR for the loved one. And very clearly, again, when family members were present, there was a decrease in PTSD, anxiety, and depression. And this was sustained after 1 year of patient death, showing very clearly that the benefit that you can provide is very much long-standing, and there is a true benefit, and as you can imagine, a reduction in consumption of healthcare resources. People go to work more easily. When PTSD is absent, it's really a much better life. And this is another study, a very nice one performed in Italy. It's a 2-year study with alternance of open and closed ICU to see whether there were benefits at the patient level. And as you can see, the family presence increased the number of bacteria, fungi, and infection in the air, but not in the patients. And it was a very safe intervention. No increase in ICU-acquired infection, but benefits for any cardiovascular complication. This was a trial that was really a proof of concept about feasibility, and our colleagues from Brazil have performed 2 years ago a very large trial with a cluster randomized control trial with either a flexible visitation policy or a restricted usual visitation policy, and they targeted patient delirium, and actually delirium was not different. You can see that the time of visitation was very different. Delirium was not different, but family anxiety and depression was much reduced. Satisfaction was improved, and at the level of healthcare providers, it was not harmful. So not only the intervention improves the family experience without worsening other elements. And again, on interventions, before getting to the last part of my presentation, we have these, what we call facilitators. It's usually a nurse making the bridge between family members and healthcare providers. And in this study, that is now being confirmed in 2 different trials by Randy Curtis in France and in the US, there was a decrease in depression. And in this other study performed in Seattle, which is a before-after study, there was also benefits at the level, at the patient level and the family level, with an improvement in the quality of dying and death. I would like to end my presentation, and I think I still have something like 8 minutes to consider things differently. This is a very nice letter published in JAMA Internal Medicine by a daughter, which is also a doctor, saying, well, the best I can do for my patients, and here it was her dad, it's to provide my advice rather than imposing my advice. And then the patient is right, because the patient makes the decision. The Family End-of-Life Conference has also demonstrated how much putting the patient at the center, rather than the family or the doctor, decreases guilt for everyone and improves the family experience, but also healthcare provider experience. And the other thing is that if we want to affiliate to each other, we need to accept that decisions have to be made, but also communication has to be improved. So let's take the first example, and I think one of the best that exists in the literature is about the qualitative interventions that provides evidence that just listening to family members allows us to understand them in their own words. So this is how family members define high quality ICU palliative care interventions. It's about communication, it's about patient-focused medical decision-making, it's about dignity, privacy, and also the care of family members. So there is this emotional paradox where family members need us to build their trust. So if we want to build their trust, we need to listen to their words, and we know that each family member will have different preferences and values. So there is not one rule that can really be applied for everyone. We need to understand who is the family and what kind of relationship they expect from us. Do they want to do and to get the power? And then we can maybe think on what are the appropriate outcomes for those family members. Or do they want us to build their trust, making them maybe vulnerable at the ICU time, but certainly preserve their dignity and reduce the feeling of guilt. So when we look at empirical studies and qualitative studies, we understand that one of the main thing that makes a better balanced relationship at the end of life is that they expect from us that we build their trust. The facilitated values history is this ability that clinicians and researchers have to listen to family members and build frameworks that really help us to assist family members at the end of life, but of course, not the same intervention for everyone. We need to understand what they want and to build on what they want. So this takes us to philosophy, because then everything has to be discussed. Sometimes it's evident, it's brain death, it's intractable medical condition or irreversible multiple organ dysfunction. So it seems obvious, so that we don't make efforts to get the family members in our side and to build their trust. But even in these very extreme cases, we don't need to use medical authority. We need to use the ethics of discussion. Everything has to be discussed. We need to go to family members and to discuss even what is obvious, to create a debate. And of course, even if the debate is a little bit, I would say, obvious, because we know that the outcome is here already, but creating this debate alleviates the guilt and help family members to build on bereavement and to feel better after patient death. So the ethics of discussion that has been described by Jürgen Habermas, who is a German philosopher, makes that every discussion has to be justified. Every point can be discussed. Even when it's obvious, you can give them the feeling that they could have been active, they could have been interacting with the shared medical decision process. It is shared between the team and the family members, even when it's obvious. Even though the events are ineluctable, the ethics replaces the moral intuition. And this is very important, because you build a dialogic test that explores what the family members expect from us, which is building on norms rather than imposing medical authority. So to forge these links with family members, we need to have many different principles. One is circularity. We consider that family members expect from us to build on trust. We need to affiliate to family members. Obviously, you go to them and you accept their style, you care for them, you are concerned, and you are not someone imposing, you are someone listening and looking. So you use the basic medical skills, which are observation and listening. You will respect their time scale, and sometimes only 2 or 3 hours waiting for someone to come from abroad or from a very long distance is something that has a very important consequence on bereavement. You need to respect the symptom and to build on trust. And you need to share and the decisions, but at the same time to show empathy as much as you can. And even if it's a little bit, family members will provide a year after, when you interview them, it's something that they say, well, I would never expect that this doctor was able to show so much empathy. So this relationship with family members will allow you to reframe. You are going to empower them, to reframe the situation, to understand their vision, to connect to them, and they will be so surprised that you will be trust. And this requires different elements. One is involving the interdisciplinary team, everyone in the ICU, doctors, nurses, and other allied professionals, but also sometimes the consultants and everyone knowing the family member, so that the family members will build trust and the trust they need to accept end-of-life decision-making. So you need to mobilize resources, competencies, and abilities to be able to change the focus and really build their trust. And sometimes you need to say and to voice yourself what you feel. You can say to family members, I admire you. Or compared to our everyday practice, we see many family members, and you are really unique in how much you provide to the patient and how much you are important for her or for him. One last point is that you need to do that in a good timeline. You don't need to miss the threshold moment. And for every patient, the moment is different, according to whether he is with a vulnerable, frail, or with difficult medical conditions, a surgical patient, a medical patient. So you need to provide them with what they expect from you at the right time. So you need to make the difference between providing a treatment and making limits and providing a time-limited trial so that they can expect from the beginning what is going to happen in a patient who is very sick and with a high risk of dying in the ICU. So I consider that we, the ICU team, we can target resilience in the
Hello?
I think we just lost the end of the presentation, but I think we had the conclusions there in front of us, and that was a wonderful presentation from Ellie. So let's go straight to, thank you so much, Ellie. Let's go, Maurizio, would you like to ask the first question?
Yeah, I do. And thank you all. First of all, Stefano and Ellie, fantastic presentations. And Ellie, I'm sure you can comment on your very last take-home message, which we saw on the screen anyway. Maybe I ask with you so that you can finish your presentation, and then also Stefano, you can comment. We are receiving a lot of questions. One question is quite interesting in the sense that do you think that by bringing non-invasive ventilation, which is a technology, at the end of life, we are actually kind of interfering by making dying a more medical process? Ellie?
Well, that's a very important question because we are still having, I think that there are two kinds of palliative NIV. The type 2 that is providing palliative care NIV in patients who are DNI with the hope that they will pass the event is really a time-limited trial, and we need to provide the technology. At the same time, we are providing palliative care and other elements of communication with family members that are part of the palliative care intervention. For the type 3, where we are accompanying family members with NIV and they are dying, to reduce the need for morphine, which I'm less convinced. But otherwise, if we have the hope that the patient can benefit and to avoid mechanical ventilation, intubation, so then yes, we need to provide NIV, time-limited trial, and communication.
I think, Anita, you want to...
Thank you. Yeah, thank you, Ellie. Stefano, there's a question coming through. A participant comments, I would never measure a blood gas at the end of life. I think that, let's see what you think. I think that may reflect a confusion between palliation and end of life. And you did say a subgroup with hypercapnia responded. I wondered if you'd like to comment on the measurement of blood gases.
Okay, yes, it's very good comment. And I apologize up to one point because in my last slide I show arterial blood gases, but this was meant to illustrate to people how the disease was progressing. And remember, that specific case, the patient was asking support to see his relatives. So there was a sort of agreement between us and the patient. But I agree with the participant. We never record arterial blood gases when NIV is applied as a type 3 palliative tool. And I remind to you another thing that I showed in my presentation and probably was not clear enough. After 1 hour, if dyspnea increased, or even worse, if the patient is not tolerant, it's the patient that is driving you. It's not you that are driving the patient. It's the patient that decide if the application of NIV may relieve their dyspnea or not. I found with Eddie comment absolutely good, but on one other side, I see too many people dying with dyspnea in the medical world, in the emergency room, and so I think these lectures are good because you can increase the threshold of knowledge about this problem in the hospitals. I still, in my country, I don't know what Maurizio think about it because we share the same country, we still see so many people dying with severe dyspnea. So I agree that probably opioids, maybe high flow nasal cannula, may be better option than NIV, but we still need to do something. We do for pain, we should do it for dyspnea.
It's very interesting what you say, Stefano. One of the things that we tried to do in my hospital was actually to find a way also with the multidisciplinary team to be very clear about the goals that you have, with the patient, with the family, but also with the teams, which leads me indeed to the next question. When you have an NIV or when you have a CPAP, people just see the device. But there is a lot of thinking and discussion with the patients, with the family, with the team. The example of Ellie before, a patient with a DNR, and you think that you want to try some CPAP, and then the CPAP does not work. How do you communicate that clarity about the goals of care with the patients, with the families, but also with the teams, because sometimes they do change? I'm interested in the answer from both of you. Stefano, maybe first.
I mean, every decision, at least here where we work, is shared with a group. I mean, we share especially with nurses, actually, when we talk with relatives, because the other problem is we see mostly patients with chronic respiratory disorders, even some very acutely with hypoxia, COVID, etc. But I would say 50% of them are not fully competent to really understand very well the meaning of this therapy. So we put together nurses, doctors, and fellows with the family members to try to better explain. And basically what we do is what has been suggested before by Lee. I mean, is it a DNI order? Now we have a law in Italy, controversial, but still we have a law, or palliative tool. But palliative tool, once more, should be only limited according to the wish of the patient and to the tolerance of the patient.
Ellie, how do you define, the goals of care, and when the goals change sometimes because the situation clearly changes, how do you communicate this?
Of course, I think that the most important thing is that we need to have a continuum with the people at stake. One is when we start a palliative care intervention, the patient, when it's possible, the family, and of course healthcare providers need to be aligned with the goals of care. Sometimes you have to negotiate, sometimes you have to improve the relationship because the patient and the family members come from elsewhere. But overall, it's not something you do when the things are worsening. It's something you do when you are implementing the strategy. So not missing the threshold moment.
Yeah, if I may say one thing, Lee, you work in the, let's say, classical ICU as Maurizio. Me and Anita, we were working in a sort of high dependency unit. And I would say that at least 30% of the patient, we know them, then they come to our unit because they are chronic patients in which we had the time before to speak about these issues. And I think this makes probably a huge difference because people can change their mind, the relatives can change their mind, but still they know what we are talking about, at least. And most of them, they try once in a lifetime, maybe high flow or oxygen or NIV, whatever. So they already know more or less what we're talking about.
Agreed. And just a quick point, as we've only a few minutes left. As societies, we've done a lot with skills training, and we do a lot with the skills of NIV, being slick with the application, choice of mask settings and so forth, same with invasive ventilation, even ECMO. I think the skills are just important as understanding when a treatment is failing and no longer appropriate for the patient, and that we move on to another phase of management. I think possibly, and it's the same as your supportive communication, Ellie, that is just as important as a practical skill.
Anita, just a small comment. Is that we have criteria to understand when it's failing. Ahead of that, 2 or 3 days before, we need to empower family members and bring them elements for them to understand it's going to fail. Empowering them, making that our medical authority disappears and we share a process by thinking on them a year later. And this is something that we need to build on. they need to trust us more. I think that this is the main catchword of my presentation.
And I have to say, some of the best experiences that I have from a very difficult moment in the pandemic is being exactly this, working with respiratory teams and other stakeholders, and working on the escalation plans and forecasting the future 2-3 days before, so that you have these conversations in a calm environment, not at 3 o'clock at night when the patient is about to fail in the last minute. So I completely agree. This is very, very important. Anita, I think we are coming to the end. It was a wonderful webinar, or maybe I leave to you the closing remarks.
Well, I would just echo that. I think we've explored a lot of ground. It's very helpful. It's a difficult area, but we've moved forward. I thank very much Stefano, Anneli, and you, Maurizio, and I hope we can do more of these webinars. Thank you so much.
Certainly. Thank you.
Have a good day.
Bye-bye.
Bye-bye.
We are